Thank you very much for that very nice introduction. Today I'm going to give you our data, actually, unpublished data on the use of Xpert Ultra directly in blood and mycolytic blood culture to enhance TB diagnostic in patients with advanced HIV disease. So what are the challenges in TB diagnosis in patients with advanced HIV disease? TB is a leading cause of hospitalization and death in patients with advanced HIV disease, and the mortality is very high, 30%, despite treatment. TB in advanced HIV disease often disseminates outside of the lungs and causing bloodstream infection, but the blood compartment has been overlooked for diagnosis for TB. And there's several reasons for that. Reason number one is that we don't do TB blood culture very often, particularly in where TB burden is very high. We don't do TB blood culture at all. Second is because Xpert or any molecular diagnostic is very difficult to do it in blood because of the heme component of red cell. It inhibits PCR. And so even the Xpert, the commercial the commercial industry that make the Xpert didn't even work out how to get rid of the heme. And so we have TB allele assay, but it has very low sensitivity and specificity. It has only 30% sensitivity. Specificity with the rollout of TB LAM has become an issue. We've been noticing a lot more specificity problem. And so, we're really stuck with Xpert in the sputum. We have sputum, we have lymph node, Xpert, microscopy, and culture of non-blood specimen. But in TB, in patients with advanced HIV disease, TB is in the blood, and we had not been able to do that. So in this study, we explore the possibility of Xpert being done directly in blood after we process the blood to get rid of heme, and then we're going to do TB blood culture to see how we can improve diagnostic of TB. And so this study is actually part of a multi-center triple fungal and mycobacterial screening program funded by the NIH. We just finished recruitment of 900 patients. We recruited 1,100 patients in 3 hospitals across Vietnam, in patients who were hospitalized with a CD4 count less than 100 and WHO status stage 3 or 4 disease. We recruited 900 patients, and for fungal diseases, that's a different talk that we did earlier today. We did intensive fungal screening with crypto, histo, and Talamyces antigen tests, in addition to the standard, which is microscopy and culture. For mycobacterial infections, we, in addition to microscopy, Xpert, AMGIT culture, we did Xpert directly in blood and blood culture for TB. Towards the end, we also added Xpert Ultra in the urine of 176 patients because we learned from a study in South Africa that you could actually do Xpert in the urine directly, and that's what we did. So today I'm going to give you the focus analysis on the TB component of this research program. And so for TB diagnostic algorithm, like I mentioned, we have conventional diagnostic here. For the intensified approach, in addition to the conventional, for blood sample, we did Ultra Xpert directly in blood. By pre-processing the blood, we treat them with 3% acetic acid to get rid of heme component, and then we put them through the Xpert just like anything else. And then we did MycoF Lytic blood culture, which is a mycobacteria specialized blood culture system, incubate for 42 days. That also grow fungus, by the way, dimorphic fungi, by the way. And then for urine sample, as I mentioned, we did Ultra Xpert in the urine. Now, if any of these specimens positive for TB, we treat, of course. If the blood culture turned positive, we did an AFB smear And if that's positive conventionally, we subculture these sample on a solid media for another 8 weeks. This is what we're doing right now as a conventional. We subculture them on a solid media for 8 weeks, and then we do light probe assay, which is a molecular diagnostic applied directly on colony growth from the solid media to make a diagnosis whether whatever is growing in the blood, whether it's TB or whether it's non-TB mycobacteria. This entire process can take 6 weeks in addition to another 8 weeks. That's 14 weeks. And these patients have disseminated disease. As you can imagine that the patient would die before you make the diagnosis. And this is why blood culture is not being useful for diagnosis of TB. But what we're proposing here, in addition to doing Xpert directly in blood sample, we also apply rapid testing, including Ultra Xpert directly on a positive culture or an antigen test called TBC, not FDA approved, but approved in Asia. Apply directly on a positive culture, and if it's positive, we can treat for TB and bypass these 8 weeks of solid media culture would take so long. So this is our intervention. And the primary outcome is diagnostic yield of this intensive approach in addition to conventional. And secondary outcome is really the burden of disease and the clinical features of TB and non-TB mycobacteria. And so the primary objective, as I mentioned, is just a diagnostic yield. And the goal eventually is to develop an algorithm to improve diagnosis and treatment of TB in patients with advanced HIV disease. So as part of the big program of research that I mentioned, I wanted to show you the data. We could see here, fungal made up about 25% of all patients hospitalized with advanced HIV disease, talomycosis 20%, crypto 5%, and histoplasmosis 3%. TB and non-TB mycobacteria collectively make up more than 30%, and this is microbiology confirmed TB. We're not even talking about clinical TB that is not confirmed by mycobacteria. So collectively, these 5 pathogens make up 55% of opportunistic infection in patients with advanced HIV disease. So this collective program really can make rapid diagnosis on these patients. So with the focus on TB result here, what you have here, we end up having 312 patients with microbiology confirmed tuberculosis, or mycobacteria, sorry. And of those, 284 have TB, 28 have only positive AFB, but not confirmed by culture or molecular diagnostic. Of those 284, 222 have TB, 27 have TB and NTM co-infection, and 35 had non-TB mycobacteria. And as you could see, that all the patients with non-TB mycobacteria, the vast majority has MAC. So MAC make up 24 out of 27 case here of the NTM, and over here MAC make up 31 out of 35. So you could see that the vast majority of non-TB mycobacteria, MAC is the number 1. And that's really helpful because that means we can empirically treat these patients if they're not TB. And we also had clinical TB in 137 patients whom we didn't have any evidence of TB, but they had compatible clinical syndrome, and the clinician treat them for TB and they got better. So clearly, together, they're 50% of burden of patients with advanced HIV disease. Massive. This study really showed that TB is a massive problem in Southeast Asia. What are the characteristics of patient population? I just want to quickly go through. The more male dominant, but only 86 versus 81%, so not big different. The majority of patients were recruited from Ho Chi Minh City, less from Hanoi, and that's just the function of us having a much bigger reference center in Ho Chi Minh City. Clinical features, you could see they have more fever, 94 versus 83% in the cohort with TB and no TB, more cough, more hepatosplenomegaly, more diarrhea. For laboratory abnormalities, you could see that CD4 count is lower in patient with TB. Hemoglobin is lower. Albumin is lower. LDH is higher, 380 versus 300. Abnormality in chest X-ray and have more incidence of liver and spleen abscesses. And so here's a big result of the diagnostic yield of the intensified approach. As you could see here, the intensified approach diagnose 92 additional cases compared to the standard approach. And the overlapping is 105. And so this is basically about 57%. I have a different slide, but I couldn't upload the new set of slides because my laptop went dead, sorry, this afternoon. But anyway, this is 57% increase in diagnostic yield with the intensified approach. And as you could see, a lot more TB, a lot more NTM. Most of the NTM were not diagnosed by the conventional method. Here are the results of the 51 patients whom we have both blood and urine Xpert in pair sample. And you could see that, again, 20 out of 31 patients here was picked up by intensified approach alone. And of those, interestingly, you could see that there's not much overlap between blood culture, gene Xpert in blood, and urine. You think that these are all the same compartment, right? You think that urine is basically another compartment of blood, and if the patient have positive blood culture, you think that they would pick up in the gene Xpert, but actually not. The overlap is low, and we don't really know how to explain this, but clearly it's important then to use multiple diagnostic tool that you have to improve diagnosis of TB. And you know that gene Xpert is highly specific, so clearly that you can make rapid diagnosis using these rapid diagnostic in addition to blood cultures. So what about the utility of doing rapid diagnostic tests for positive blood culture? As I mentioned earlier, right now we waited another 8 weeks to do subculture on solid media, and if you apply gene Xpert directly on a positive blood culture, you apply the same, treat it with acetic acid to remove heme, and you subject them to gene Xpert. What happened? What is the diagnostic yield? Look at this. Sensitivity is 98% compared to the LPA gold standard, reference standard, and specificity is 100% in 44 plus 27. So in this patient group, the gene Xpert directly in positive culture is highly sensitive and specific in making a rapid diagnosis and cut the time to diagnosis by more than half. How about the TBC, the antigen test that I mentioned? Actually not so bad. The antigen had 90%, 91% sensitivity. It misses 4 cases, whereas the gene Xpert misses only 4 cases, but highly specific. So these tests is available. These are available right now. They just don't use because people don't pre-treat the specimen, and these can be done right now to cut down TB diagnostic algorithm. What about survival in different group of mycobacterial patients? As you could see here, mono infection with TB, mono infection with NTM, and no TB infection, the death rate is about the same, 20 to about 25%. But people with clinical TB had much higher death rate of almost 40%. And people with TB and NTM co-infection, mortality is 50%. And I think the reason why clinical TB has such high mortality is because the prolonged time. You know, we don't treat for TB unless you rule out other diagnostic and until they don't respond to antibiotics, they don't respond to, you know, other on the diagnostic workups are negative. So by the time you decide to treat for TB, the patient is kind of late. So you could see that it's really important to make rapid diagnosis. So we did come up with a TB diagnostic and treatment algorithm, And we need to work further on this. This is just very preliminary, but essentially what we propose for a place where TB burden is more than 30%, because it's totally worth it if you do this screening algorithm. If your TB burden is more than 30%, and I suspect in many settings, TB burden is more than 30% in advanced HIV disease, you could basically do rapid TB tests using Xpert directly in blood, the conventional diagnostic that you have right now. And if it's positive, you could treat the patient right away, particularly those that had Xpert directly in blood positive. For blood culture, I think there's still a role, like I mentioned, because they pick up disease that are missed by these, as you could see, as I've shown before. And the algorithm is that if AFB positive, you can start the patient on TB therapy right away. And then you apply the rapid diagnostic with Xpert or TBC antigen on a positive blood culture. If that is positive, you can be confident that you're just treating TB. But if it's negative, you can add MAC therapy, because very likely that these patients have MAC. NTM would be most likely MAC. And so you can add azithromycin to your TB regimen, and you will cover the bases without waiting, sending the sample to a biosafety 3 level for TB culture, and then do LPA 2 months later. By then, the patient would have been dead. And so I think that this algorithm is what we would propose based on our study. So in summary and conclusion, confirmed mycobacterial infection make up 35% of all OI, and 50% if you include clinical TB. Xpert in blood and blood culture for TB increased diagnostic yield for mycobacteria by almost 60% and 45% for TB. Among the patients that TB was diagnosed by the intensified approach only, 75% of those were diagnosed by Xpert in blood alone. That means that you can start earlier therapy right at the time the patient come in, because Xpert only take a couple hours. Really can improve diagnosis of these patients. There's still very high mortality, particularly with TB and NTM co-infected patients, and very high mortality in clinical TB because we missed TB diagnostic in those people. And so very high clinical suspicion in people, even though TB diagnostic is negative, and remain, be very, have low threshold to start clinical empirical therapy for TB to save life. And finally, Xpert Ultra and TBC directly in blood culture positive sample have very high sensitivity, high specificity, high positive predicted value and negative predictive value for rapid method that can shorten the downstream identification of mycobacterial blood culture infections. I want to thank my research team at Duke in the Tropical Medicine Research Center in Vietnam, and my collaborator in Vietnam, and our research funder. Thank you for your attention.
Yeah.